Good afternoon. It is my pleasure today to change the talks from treatment to prevention, preventive nephrology, prevention of diabetic kidney disease. When we speak about prevention of diabetic kidney disease, we may speak about primary prevention of diabetic kidney disease through avoiding diabetes, the reversal or inducing remission of diabetic kidney disease, retarding the progression or slowing progression or enhancing regression of diabetic kidney disease. All these issues are very interesting and very exciting, and we hope that through our clinical activities we can achieve these hopes, because prevention is better than cure. I enjoyed this session within the Pan-Arab Diabetes between two eminent speakers. One of them defended prevention is the best way to limit epidemic of diabetes, and the second one, reversal is the best way to limit the epidemic of diabetes. I agree about the two concepts, and I like to have them. So either prevention or reversal of diabetes in general, or diabetic kidney disease after that, all these are very important and exciting issues. I reviewed a lot of data in a lot of slides, but today I'm going to present some of them under the following corners: introduction, followed by comment on anti-hyperglycemic drugs, other dimensions of management of diabetic kidney disease away from correcting hyperglycemia, lessons from basic research, and I'll end with an interesting issue: comprehensive multifactorial risk management of diabetic kidney disease. To start with, diabetes, if it's associated with proteinuria or significant reduction of kidney disease, this means CKD, severe CKD, both of these situations are very high risk for cardiovascular disease and for mortality later on. Hyperglycemia is bad through molecular changes, genetic modification, epigenetic regulation disturbance, podocyte autophagy reduction, mitochondrial dysfunction. All these factors can lead to many other pathways, ending in a well-established nephropathy and renal dysfunction. So we should understand all these parameters, doing a lot of research, and to improve the management of diabetic kidney disease. One of the reasons that we are in urgent need of improving diabetic kidney disease management, at least to avoid the fast progression of diabetic kidney disease or retard the progression, if we cannot succeed to reverse it, because diabetes is still the leading cause of end-stage kidney disease within the United States, according to the last report of United States Renal Data System. Really, diabetic nephropathy can be reversed. According to this old article, you can find here the well-established diabetic glomerulosclerosis on time 0 is reversed after 10 years of pancreas transplantation. Another exciting data from a case from Japan. Here, the donor of a diabetic kidney with proven diabetic nephropathy as evidenced by histology. This lesion is reversed after transplanting the kidney from a diabetic donor to a non-diabetic recipient. The evidence is from this histology. This is electron microscope after 1 hour, here 1 month, and 1 year. You can look here, very thickened base membrane. This means diabetic glomerulopathy. And here, normalization after a year of transplanting this kidney in non-diabetic environment. In a rat, islet transplantation normalizes the pentraxine tree. This means that it reversed the pathology of diabetic kidney disease. One of the important clinical issue is to work earlier for targeting hyperfiltration. Hyperfiltration occurs in 10 to 67% in type 1 diabetes and 60 to 70% in type 2 diabetes. Hyperfiltration means that the kidney is working maximally to reach the maximal GFR, but after a period of time, there is a loss of nephron here. After this period of time, there is loss of 50% of nephrons, and the GFR is kept within normal with the expense of increased single nephron GFR. At the end of the day, the GFR is reduced and end-stage kidney disease can occur. Why there is hyperfiltration? Because diabetic environment leads to afferent vasodilation and efferent vasoconstriction with subsequent increased hydrostatic pressure and hyperfiltration. To combat hyperfiltration, we should address all these issues. What about antihyperglycemic drugs and diabetic kidney disease? The rationale of diabetes control or hyperglycemic control. Do we target intensive glucose control to improve kidney outcome? The secret of success of intensive glucose control is earlier application. Because after establishment of stage 3, 4, chronic kidney disease, we are afraid of hypoglycemia. So intensive glucose control may be our target if we treat the patient earlier. Here, this is the randomized control trial. Here, the patients were either treated by intensive treatment or standard antihyperglycemic therapy, and the 5-year data of this randomized control study shows that the kidney parameters improved with intensive glucose control. As you can see here, there is significant reduction of microalbuminuria, macroalbuminuria, and the reduction of progression of albuminuria and increased rate of regression of albuminuria. If you compare, this is 61% regression in comparison to 56% of none of the standard care of hyperglycemic treatment. Regression to normal albuminuria, this means reversibility. Here it is very manifest here, 56%. With subsequent reduction of end-stage kidney disease. So this trial is one of the trials that showed if we adopt intensive control, especially if we start earlier, this make a great difference. This is a very nice commentary because it includes the results of the advanced trial and the long-term observation follow-up after the end of advanced trial, advance on. Here, the secret of success, as I mentioned, if we treat the patient targeting intensive glucose control, here in stage 1 and 2 to reach A1C less than 7%, here we can make a great difference because this is the after the advance on. Here, end stage occur on 0.14% and here 4%. And the number need to treat is 1 to 109 patients. So it is beneficial effect if we aggressively reduce hyperglycemia in early stages of CKD while estimated GFR is still above 60 ml per minute. But if we wait until stage 3, 60 ml per minute, the number need to treat is approximate 400 and it is very costly. So to apply intensive glycemic control, the secret of success is early adoption. And this is a review showing that intensive glucose control prevents the development and the progression of albuminuria, and most likely intensive glucose control most likely prevents glomerular hyperfiltration rate loss, GFR rate loss. The kidney benefits of intensive glucose control are most pronounced when applied to patients with early CKD before stage 3 CKD. Please look at this video that I recorded on the 22nd of July this year, including all the details for all antihyperglycemic drugs with the issue of delaying the progression of diabetic kidney disease. But this is, I'm going to present the newer data after the previous video. Here, look here, in type 2 diabetes, one of the pathophysiology of type 2 diabetes is increased expression of sodium glucose cotransporters within proximal convoluted tubule, with subsequent increased sodium reabsorption, so sodium reaching macula densa is reduced. This will lead to tubuloglomerular feedback disturbance, with subsequent afferent vasodilatation and efferent vasoconstriction, with increased hydrostatic pressure. This means increased proteinuria. So if we treat the patients with sodium glucose cotransporter 2 inhibitors, sodium reabsorption is reduced, so the level of sodium that reaches macula densa is normalized, with subsequent normalization of tubuloglomerular feedback. The subsequent results are as you see here. Afferent dilatation is reduced and efferent constriction is released. So amelioration of the hemodynamics is associated with reduction of intraglomerular pressure and reduction of proteinuria. This is very nice figure showing the effect of sodium glucose cotransporter 2 inhibitor reduces hyperfiltration. And I'd like to add this concept. What is the difference between sodium glucose cotransporter 2 inhibitors and the loop diuretics regarding natriuresis? Are they the same? The answer from this figure is actually not the same. They are different. Different in this concept. The sodium glucose cotransporters inhibitors and loop diuretics reduced interstitial volume and edema through natriuresis. But look here, intervascular volume here is this is a major difference between sodium glucose cotransporter inhibition and the loop diuretics, because loop diuretics reduce the intravascular volume significantly in comparison to sodium glucose cotransporter 2 inhibitors, and this is one of added beneficial effects of sodium glucose cotransporter 2 inhibitors on the heart. GLP-1 agonist, this one also of more recent data, from the video. Here this is this drug, dulaglutide. This is the long-acting GLP-1 receptor agonist, which is given parenterally subcutaneous once weekly. So this is the randomized study addressing the issue of the use of dulaglutides versus insulin glargine in patients with type 2 diabetes with moderate to severe chronic kidney disease. This means stage 3 to 4 chronic kidney disease. Here, this is the number of patients in each arm, 190 patients treated with dulaglutide 1.5 milligram or 0.7 milligram in comparison to insulin glargine. You can look here, the use of GLP-1 receptor agonists either in 1.5 milligram or 0.75 milligram, both doses were associated with significantly higher GFR in comparison to the insulin. This means that the use of this drug protects the kidney, and you can see here the data after 26 weeks of follow-up and 52 weeks, both formulas of the drug are associated with more preservation of estimated GFR. This article is very nice because it's a very nice review discussing the issue of major adverse renal events. And the major adverse renal events include hard endpoints like end-stage kidney disease, and this is the most important solid outcome criteria, or intermediate outcome from the renal perspectives like reduction of estimated GFR or increased serum creatinine by a level, or surrogate like biomarkers or proteomics or albuminuria, increased albuminuria. So all these are the endpoints in a major adverse renal events. This table summarizes the results of different antidiabetic drugs, and I explained this table within the videotape of oral antidiabetic drugs. Please look at this video. Here you can see sodium glucose cotransporter inhibitor, especially empagliflozin, was associated with significant reduction of the composite endpoints, new onset diabetic kidney disease, albuminuria, occurrence of end-stage kidney disease is reduced significantly, and death from any cause is reduced by using empagliflozin as one of sodium glucose cotransporter 2 inhibitors. Please look at the video. Is there any effect on inflammation? Yes, the newer classes of antidiabetic drugs have anti-inflammatory effects like GLP-1 receptor agonists, DPP-4 inhibitors, and sodium glucose cotransporter 2 inhibitors. Other dimensions of management. I'm here going to focus on one of important sector within this presentation is to target modifiable risk factors like overweight and obesity through applying proper diet and exercise, so through lifestyle modification. This is one of very interesting data, a change in overweight from childhood to early adulthood and risk of type 2 diabetes, including 62,000 Danish men. Here, if the just overweight is here in this period of time, before the puberty time, here you can look at the hazard ratio of type 2 diabetes. This is the one. If the overweight continues, you can find the risk of diabetes increases, especially if it continued until the adulthood life. Here diabetes is increased fourfold. So controlling body weight is good news to prevent diabetes, and if we prevent diabetes, this is a primary prevention against the diabetic kidney disease. So here, if we go to overweight, so this is overweight all through the times, in early childhood, in the puberty time, and in the early adulthood. Here, the risk of diabetes increases significantly. But if we go here, the risk of diabetes is reduced. This means that we should encourage with management for all individuals in the community. What is the rationale of caloric restriction? This is one of the concepts in the cell published in Cell Metabolism this year. Mechanism by which a very low calorie diet reverses hyperglycemia in a rat model of type 2 diabetes. A 3-day very low calorie diet reverses type 2 diabetes in rats by multiple mechanisms. A very low calorie diets lower hepatic acetyl-CoA. As you see, if you just focus here in type 2 diabetes, there is increased acetyl-CoA. If you apply low calorie diet, you will reverse this issue, as well as gluconeogenesis and glycogenolysis. So a very low diet lower hepatic acetyl-CoA glycogenolysis and this molecules activation. So a very low calorie diet markedly improves hepatic, not peripheral, insulin sensitivity in type 2 diabetic rats. So this is one of the mechanisms. Let me to shift to the kidney, because I'm speaking about the kidney. There are now Adipo-Renal Axis or adipocytes kidney crosstalks. And this is a very nice review that is published this year. This is the healthy adipocytes. Healthy adipocytes is an endocrine, is a factory of endocrinal system. So the healthy adipocytes secretes a normal mediators and endocrinal and hormones. But if the adipocyte is hypertrophied in obesity with caloric stress and over calories, what happened? Insulin resistant, dyslipidemia, macrophage accumulation, inflammation, adipokine dysfunction, with subsequent oxidative stress and inflammation. So you can find here disturbance of all these mediators. In obesity, there is increased leptin, decrease the adiponectin, increase the angiotensin 2, increase the TNF, increase the metabolites, and polarization of macrophages in the kidney from M2 to M1 to pro-inflammatory macrophages. So a lot of issues are linking adiposity and obesity with the kidney. Again, this is the renin-angiotensin axis. Angiotensin 1 is converted into angiotensin 2. So in obesity, there is increased angiotensin 2. Angiotensin 2 work on angiotensin 2 type 1 receptor. This type 1 receptor is increased with subsequent polarization of macrophage toward M1 after macrophage accumulation and inflammation with subsequent renal dysfunction. If we ameliorate angiotensin 2 type 1 receptor by angiotensin 2 type 2 receptor, this angiotensin 2 type 1 receptor is beneficial. Angiotensin 2 type 1 receptor is harmful. In obesity, angiotensin 2 type 1 receptor, which is a bad receptor, is exaggerated. Leptin, through leptin receptors or TGF-beta receptor, leptin leads to all these molecular mechanisms leading to increased fibrosis through TGF-beta and other factors. So again, these are very bad issues. Reduction of adiponectin leads to renal fibrosis and glomerulosclerosis and albuminuria. So if we succeed to reverse all these changes through treating leptin by leptin blockers or antibodies against leptin, or increasing the adiponectin by using all these like resveratrol, which is antioxidant, and berberine, and this molecule, this may ameliorate kidney disease. Again, this cartoon shows how adiposity and obesity leads to increased growth factors like TGF-beta, increased acute phase reactants, reduced adiponectin, increased leptin, increased complement and complement system molecules, also increased cytokines, interleukins like interleukin 6, TNF-alpha and chemokines, and increases intra-abdominal pressure. All these factors can lead to cardiovascular and kidney disorders. In kidney, there is micro and macro albuminuria, obesity-related glomerulopathy. This is a clinical term that all nephrologists are aware by obesity-related glomerulopathy, increasing sympathetic system activity and renin-angiotensin system, increased immune activation, oxidative stress, and kidney stones. So we should combat obesity. We don't like obesity. We should combat, because obesity is associated with high leptin, and high leptin is associated with all these bad effects, including inflammation and kidney fibrosis and endothelial dysfunction. And you can see here, leptin, excessive leptin is associated with CKD. Increased leptin levels have been associated with the presence, severity, and the progression of CKD. Increased leptin levels have been associated with development of type 2 diabetes, as well with micro and macrovascular diabetic complications. So we don't like increased leptin that is induced by obesity. Is there any randomized, in an open label randomized control study? This is the first one, direct trial. This is a primary care led weight management for remission of type 2 diabetes. Again, remission of type 2 diabetes. And this is the number of patients. This is the interventional group, 149 patients, and in the control group, 149 patients. The results is, if we apply weight management and focus on it, the intervention group, there is increased proportion of patients who achieved a reduction of body weight by 15 kilogram or more. So this is a very, and with subsequent achieving remission of diabetes by 46%. So diabetes can reverse with weight management. we are honored that we know Professor Osama Hamdi. He is originally from Mansoura University and is now associate professor of endocrinology at Joslin Diabetes Center. And these are two important articles from his publications: weight management in patients with type 2 diabetes, a multidisciplinary real-world approach, and weight management in type 1 diabetes. So multidisciplinary means that all these persons work together. We need a dietitian, we need psychologists, we need exercise physiotherapists and physiologists and healthcare providers. All these personnel work together trying to reach good diet and exercise. And if this approach fails, we may think of bariatric surgery or metabolic surgery. Another important issue within the review of Professor Osama Hamdi is when we select antidiabetic drugs, we should think of weight gain. So this is the list of weight gain drugs. Sulfonylurea are associated with weight gain. Insulin is associated with weight gain. Ribaglinide and netiglinide are associated with weight gain. Metformin is neutral. DB4 inhibitors are neutral. But here, GLP-1 receptor analogs, sodium glucose cotransporter inhibitors, these two classes, and the amylin analogs, all these, so GLP-1 receptor analogs, sodium glucose cotransporter inhibitors reduce body weight and correct KG-A1C paradox, because the dogma of reducing A1C, when it is associated with increased body weight like sulfonylurea treatment, this will reduces the beneficial effect of glycemic control. So we have now these two classes of drugs, and they are available even here in the Egyptian market: GLP-1 receptor analogs and sodium glucose cotransporter inhibitors. One of important issue is to respect our biological clock. We have central clock in the hypothalamus and the peripheral in all tissues, including even the kidney. GFR and tubular secretion or absorptions are based on clocks, peripheral clocks, controlled by central clocks. But here I'm speaking about the clock in the central and in the adipose tissue, white and the brown clock. What is the message? The message is this clock helps us, if we follow the beneficial, the normal behavior of avoiding eating late night, because this will disturb the central clock and increase adiposity and bad issues. So we have another term, metabolic flexibility, as an adaptation to energy, resources, and requirements in health and disease. The metabolic flexibility is associated with normal mitochondria. If we disturb metabolic flexibility by overfeeding and by eating all through the day and nights, all these issues disturb the clock in the fat and disturb the metabolic flexibility, leading to metabolic mitochondrial dysfunction. Is there any data? This is a very nice review about diet and diabetic kidney disease, discussing the issue of plant versus animal protein. And this is a very nice review, still impressed about vegetarian diets and chronic kidney disease, not only diabetics. And this is the rationale of encouraging vegetarian diets, especially if we deal with the patient earlier before the advanced CKD, because in advanced CKD, we may be afraid of hyperkalemia. But if we start earlier, encouraging the percentage of vegetarian diet and increasing plant diet in food, this will be associated with reduction of fat, reduction of carbohydrate, increasing fibers, reducing proteins, decreasing phosphorus, reducing uric acid, and reducing salt, with subsequent improvement and of adipose tissue dysfunction, beta cell dysfunction, insulin resistance, and endothelial dysfunction with subsequent cardiovascular and kidney improvement. So would you please encourage and put this concept in mind? And this is why we have at Mansoura Faculty of Medicine, nowadays we have the Fellowship of Renal Nutrition for 2 years of training, and we finished the first year for this group of candidates. I'm here working and collaborating with Dr. Dua Hamid, the consultant of nutrition. So this is specialized nutritionist, and these are the newcomers of experts in the renal nutrition. Regarding metabolic surgery, this is the concept. If the patient is if the patient is obese, obesity, especially if it's marked, is associated with afferent vasodilation and hyperfiltration. After bariatric surgery corrects this hyperfiltration through amelioration of afferent vasodilatation. This is the data, very interesting data. A total of 50,000 entries were analyzed. And this is the different metabolic surgeries done, either gastric band, as you see, gastric band, and the Roux-en-Y, and vertical sleeve gastrectomy. This means that there is increasing trend toward using vertical sleeve gastrectomy and reduction of Roux-en-Y gastric bypass. But the data are encouraging. If there is an indication for metabolic surgery, the data are very, very hopeful. The prevalence of diabetes is reduced by 50% after doing metabolic surgery. So metabolic surgery is associated with halving the proportion of patients with diabetes-related hyperglycemia. This is from the American Diabetes Association guidelines, and this is the diabetic care supplements of the 2018 standards for treatment of diabetes, showing that metabolic surgery may be thought if we fail to treat diabetes, hyperglycemia by the medical treatment in a very obese person. I'm convinced by this issue, but I'm not convinced to start the metabolic surgery very early. Yes, if we have diabetes uncontrolled despite the use of maximal treatment and the patient is obese, the treatment is metabolic surgery. There are some data about the bariatric surgery and the 5-year outcome in this 150 patients who had type 2 diabetes in a randomized control study. Either sleeve gastrectomy or gastric bypass were associated with significant reduction of A1C and stoppage of medication. This is the dark color means that the patients stopped the medications for diabetes. It means after doing surgery. Gastric bypass, this is the percentage of patients who stopped antidiabetic drugs, and this is the percentage of those who stopped after sleeve gastrectomy. In comparison to medical therapy, this means that the metabolic surgery is efficient in controlling diabetes. And this is another data for 12 years of follow-up after gastric bypass, showing that type 2 diabetes is significantly reduced after doing surgery. And this is the meta-analysis of metabolic surgery versus medical treatment for microvascular complication in patients with type 2 diabetes. The literature search yielded 1,559 articles included, and at the end of the reading these articles, the authors included 10 studies. 3 of them were randomized controlled studies, and 7 of them observational controlled studies, investigating 17,000 patients. And here the data. In randomized controlled trial, here I'm not speaking about reversion of diabetes, I'm speaking about here nephropathy. Nephropathy is significantly reduced after metabolic surgery. In randomized controlled trial, and in observation controlled studies. This is the reduction of the prevalence of diabetic kidney disease or diabetic nephropathy. Here, this is the remission, reversibility of diabetic nephropathy. It was very manifest in controlled observational studies. And here it was insignificant here, but the trend toward a beneficial effect. This is one of the most recent publications in the effect of metabolic surgery. Here, they compared 4,000 patients to matched controlled non-surgical patient 11,000 versus 4,000. If you look here, the proportion of microvascular disease is significantly reduced after doing bariatric surgery. And this is the hazard ratio reduced significantly. Not only the microvascular, but also this is nephropathy. I'm speaking about the kidney. The percentage of nephropathy is significantly reduced in patients who were treated with metabolic surgery. And the hazard ratio of nephropathy is significantly reduced. Look at the data. The composite index of incidence of microvascular disease after 1 year, 3 years, 5 years, and 10 years, 7 years, 0.4. So there is a reduction by 60%. Incident diabetic nephropathy, here it is 0.45, 45. There is 55% reduction of incident diabetic nephropathy. So the trend now, I'm not going to say that it is better to replace medical treatment by metabolic surgery, but if drugs fail, please not to be late to consider metabolic surgery, because prevention is better than cure. And this is again the summary of the data. New onset microvascular complication, surgery versus medical treatment, 5% versus 15%, threefold reduction of the microvascular complication by surgery. And this is the nephropathy I'm speaking about. Nephropathy, again, threefold. And the observational studies showed the odds ratio is reduced to 0.1, and the remission and the reversibility is increased 15 folds. The odds ratio is increased 15 folds. So this data summarizes the concept that working with the patients, doing the proper management within its indication on time, this may even reverse the complications of diabetes like diabetic kidney disease. And this is this article was summarized to the patients, outcome of bariatric surgery in patients with diabetes. A new technique, a mesenteric visceral lipectomy through using tissue liquefaction technology. Here for baboon, and instead of doing omentectomy, here just removing some grams of fat from the mesentery and leaving the mesentery in a good status, avoiding injury of vessels and the nerves of the mesentery. So here, this is the grams of fat removed from the mesentery was associated, just a few grams, even here, half kilogram, was associated with significant body weight reduction after the technique and improvement of insulin resistance. Another dimension is smoking. The advice is smoking in general is a kidney poison, as I always say. Smoking is nephropoisons. And this is the study because there's some concern that smoking cessation may be associated with weight gain. So this study addresses this issue: smoking cessation, weight change, type 2 diabetes, and mortality. So this is the summary of the data regarding type 2 diabetes. If you look at this current smoker, so diabetes, the risk is 1, hazard ratio 1, adjust for multiple ratio 1 for current smokers. If the person quit smoking and after cessation of smoking, this hazards, if there is no weight gain, is here it is this is the hazards of diabetes is in recent quarters like this. But if there is weight gain, there is increased risk of type 2 diabetes. So this is the real fear. If we stop smoking and there is no weight gain, no increase in diabetes. But if we stop smoking and there is excessive weight gain, diabetes may increase by percentage. And look here, in the current smoker, mortality is 1, and irrespective to weight gain, mortality is significantly reduced after cessation of smoking. So even if there is little bit increase in the risk of diabetes because of weight change after cessation of smoking, we should stop smoking, because mortality from cardiovascular risk factor is significantly reduced whatever the weight gain after cessation of smoking. So smoking is a killer. Smoking is a killer, and stopping smoking saves life. And you can look at the hazard ratio of type 2 diabetes. Here, non-smoker at all. This is why we should encourage primary avoidance of smoking, because in primary avoidance smoking, it will protect against diabetes. But if the patient is smoker, here, this is the hazard ratio of type 2 diabetes for after stopping smoking. There is some increase, but it is not significant after a period of time. And this is the issue of weight gain after stopping smoking. And the message is, yes, there may be weight change toward weight gain after cessation of smoking, but we should stop smoking to save our lives. And the more better and the best is to avoid smoking at all, because avoiding smoking is protective against diabetes. So you may be heavier but healthier after stopping smoking. So the message is, smoking is a kidney poison. If we think of diabetes, we should encourage the people to avoid smoking altogether. Regarding proteinuria and albuminuria in diabetes, does proteinuria matter? Yes, it matters. This is the category of proteinuria and other risk here of mortality, of cardiovascular events, and end-stage kidney disease. If the albuminuria is low, less than this value, 0.5 gram per day, within normal range, in non-diabetic kidney disease is reference, it is good. In diabetic kidney disease, cardiovascular, everything is fine. But if it increased, especially if it's above 1 gram, look here, hazard risk of mortality, especially in diabetic patient, increased twofold. Cardiovascular events twofold, and end-stage kidney disease increased threefold. So we may look at proteinuria and to be target for our treatment. Again, cumulative hazards of CKD progression increased if there is increased albuminuria. So again, it is bad and increased end-stage kidney disease. And this is the change in albuminuria. Here, this is the study, included 8,000 patient baseline, and then they followed up to address if there is decrease or increase. Here, if there is decrease in albuminuria, urine albumin creatinine ratio by more than 30%, between 30 decrease less than 30%, to increase less than 30%, or increased above 30%. And this is a number of people. Look here, if albuminuria increased, the primary composite point increased. Major macrovascular events increased. Renal events increased. All-cause mortality increased. So proteinuria and albuminuria are associated with a poor outcome. As you see, all-cause mortality, if there is increased above 30%, increased mortality, major macrovascular increased if macroalbuminuria increased by 30%, major renal events increased. If it increased, albuminuria increased by 30%. All-cause mortality increased if albuminuria increased by 30%. And this is after adjusting still increasing albuminuria by 30%. This means increase albuminuria rather than decrease. Here you can find the answer is clear. All these outcomes are increased. Major macrovascular renal events, major macrovascular events, renal events, and all-cause mortality increased if albuminuria increased. And if we succeed to reduce albuminuria and to regress diabetic kidney disease, the outcome is improved. Regarding hypertension, this is the European guidelines that was released on 25th of August this year, and this is the treatment threshold in diabetic patients in this age. If it is above 140 systolic blood pressure, in 65 to 79 years above 140, if above 80, 160, this is threshold for treating hypertension, and 140 and 160 the same in diabetes and hypertension and CKD. This is the threshold of antihypertensive medication to trying to target 130 systolic blood pressure in this age range, and below 140 in this age range, and below 140 in this age in patients with more than 80 years if they are diabetic, and trying to reach 130 in CKD. And so this is the threshold and treatment target according to the European guidelines. For a diabetic person, antihypertensive drug treatment is recommended. This is level 1A if blood pressure exceeds 140/90. In people with diabetes receiving blood pressure lowering drug, it is recommended to target systolic blood pressure to 130, less than 130 if tolerated, but not less than 120. It is recommended to initiate treatment with combination of a RAS blocker with calcium channel blocker. RAS blocker either ACE inhibitors or angiotensin receptor blocker, but not to combine them, because combining them is bad and associated with harm. One of the most important issues in the European and previously in the American guidelines is stressing upon lifestyle intervention to prevent the complications. So lifestyle interventions are indicated class 1 and A for all persons, even with normal blood pressure. Salt restriction to less than 5 grams per day. Here, avoid binge drinking, increase consumption of vegetables, a proper diet, fresh fruits, fish, nuts, unsaturated fatty acids like olive oil, low consumption of red meat, and consumption of low-fat dairy products. Here, 1A. All these advices are of beneficial effect on blood pressure and on the kidney as well, either for normal persons or diabetic. This is body weight, also avoiding obesity, because obesity is bad. Regular aerobic exercise and cessation of smoking, as I mentioned. If you'd like to listen to the lifestyle and the kidney, you can go and review this video that was recorded in April this year. Is there a difference between ACE inhibitor or ARBs? According to this network meta-analysis, there is no significant difference between angiotensin converting enzymes or angiotensin receptor blockers. But if we use ACE inhibitors and there is hiccup, for example, we can use the most recent angiotensin receptor blockers. If we use RAS blockers, which is the best class to be added? The best class to be added is calcium channel blocker based on this data. If we look here, I'm not going to look at mortality and the cardiovascular events, but I focus on kidney. Here, if you use calcium channel blocker, the hazard ratio of kidney events is reduced to this value 0.8 here, and it is significant. And if you use the loop diuretics, increased 1.7. So for targeting proper kidney, it is better to add calcium channel blocker to RAS blockers. Regarding the issue of stroke volume, in obesity-related glomerulopathy, there is increased blood volume and stroke volume increased, and subsequent proteinuria. So this is why you may find some beneficial effects of drugs targeting the stroke volume like diuretics or beta blockers or benefits in obesity-related glomerulopathy. If the patient is hypothyroid and diabetic, please don't forget to correct hypothyroidism, because correction of hypothyroidism is beneficial to the kidney as shown in this randomized double-blind and placebo-controlled study. Gut microbiome. We have many gut microbiome within our gut. And this is a study, a randomized controlled study for 8 weeks, including 48 diabetic nephropathy patients. The patients were randomly allocated into probiotic soy milk consumption. So soy milk plus the microbiome probiotic, and the control was soy milk only. So this study shows some beneficial effects of probiotic supplementation, and we are waiting a lot of evidence for this issue. Regarding resveratrol, which is antioxidant, this is a double-blind placebo-controlled clinical trial. 60 patients with type 2 diabetes and albuminuria with diabetic kidney disease were randomly assigned to receive either resveratrol 500 milligram per day or placebo for 90 days. You can look here. Urinary albumin is significantly reduced in comparison to increased albuminuria in placebo by the use of this antioxidant drug, resveratrol. Another drug, which is JAK inhibitors, JAK1 and JAK2 inhibition by this drug, Bariatric, which is reversible inhibition, leads to reversible inhibition of Janus kinase 1 and 2, and this study included this number of patients, 25, treated by 0.75 milligram per day of this drug, 0.75 twice per day, 1.5 milligram per day, or 4 milligram per day, or placebo 27 patients. And you can see here the major difference after 12 weeks. There is reduction of the albuminuria in comparison to placebo. All times the placebo there is increased 24-hour urine albumin creatinine increased in placebo in comparison to these drugs, but we need further studies. What about basic research? There are a lot of issues regarding methylation and epigenetic programming leading to histone modification. Epigenetic means environment like diet, lack of exercise, toxins, and agings work with genes leading to epigenetic changes that can lead to declining renal function, inflammation, fibrosis, and apoptosis. So we need a lot of data to understand how to use drugs that modulate the abnormality in epigenetics to correct diabetic kidney disease. Metformin phosphorylates acetyl-CoA carboxylase by AMP activating protein kinase, and this essential for antifibrotic effect of metformin as shown in this experimental study. Here, renal tubular cell injury leads to in this acetyl-CoA carboxylase null mice is associated with reduction in phosphorylated acetyl-CoA carboxylase with subsequent reduction of fatty acid oxidation, lipotoxicity, and ATP generation is disturbed, leading to renal fibrosis. Metformin through AMP activating protein kinase ameliorate and increases phosphorylation of acetyl-CoA carboxylase, leading to reduction of fibrosis, and this is one of the mechanisms of nephroprotection of metformin. Sodium glucose cotransporter 2 inhibition in these diabetic mice. Here, sodium glucose cotransporter 2 inhibitors ameliorates these two pathways. But if you go and read in details this article, you will find the low calorie diet not only improves this pathway and this pathway, but also correct this pathway. So in this experimental animal, there is an important proof for the beneficial effect of low-calorie diet on the kidney, even more than sodium glucose cotransporter 2 inhibition. On non-diabetic mice, in the current issue of Kidney International, you can find a beneficial effect of sodium glucose cotransporter 2 inhibition targeting vascular endothelial growth factor that prevents renal injury in mice. So this is, if this is uninjured and untreated non-diabetic mice, glucose is absorbed through GLUT2 here to the interstitium. So this is how the glucose is reabsorbed from the lumen of the tubule to the cell to the interstitium, and the increased absorption here will lead to glucose level equilibrated. But in uninjured and treated with sodium glucose cotransporter inhibition, what happens? Sodium glucose cotransporter 2 inhibition blocks tubular absorption from the luminal side with subsequent equilibrated glucose from the interstitium through GLUT2. But in injured tubules, there is a reduction of GLUT2 expression. So with treatment with this sodium glucose cotransporter 2 inhibition, glucose is not equilibrated with subsequent increased vascular endothelial growth factor A that ameliorates damage. So sodium glucose cotransporter 2 inhibition and in renal ischemia model non-diabetic implication for future clinical trial. Here, these are the potential pathways that reduce renal ischemia with sodium glucose cotransporter 2 inhibition. Direct cardioprotective, reducing hypoxia. Modify energy substrate utilization. Decrease solutes. Reabsorption by proximal convoluted tubule, reducing hypoxia. Maybe hypoxia inducible factor stimulation. Increase erythropoietin production, increasing hematocrit and reducing hypoxia. Decreasing diuretic requirement, increase renal oxygenation through increased renal perfusion, or increased vascular endothelial growth factor A expression, leading to reduce the capillary rarefaction and the reduction of renal ischemia and fibrosis later on. So another piece from basic research showing that sodium glucose cotransporter 2 inhibitors may work in non-diabetic. We are waiting further studies in this field. NOx4, NADPH oxidase type 4, is bad, associated with oxidative stress with subsequent kidney damage. So this, if we can block NOx4, so there is experimental studies showing beneficial effects of inhibitors of NOx4 inhibitors on the kidney. Galactin-1 is a marker for renal fibrosis in type 1 and type 2 diabetes, and this study opened paved the way for searching for molecules to target galactin-1 to reduce fibrosis. To use microRNA not for as a biomarker for diagnosis, but we can use them for treating diabetic nephropathy. Silibinin, which is present in Silibinin in the management of diabetes mellitus and its complication. Silibinin, all these are beneficial effects, attenuates osteoporosis, anti-retinopathy, anti-neuropathy, anti-cardiomyopathy, anti-hepatopathy, but which is more interesting for me, it improves the kidney function, reduces oxidative stress, reduces extracellular matrices accumulation, and the glomerular basement membrane reduction. This means they improve the nephropathy, anti-nephropathy. If we succeed to harbor or increase angiotensin II type 2 receptors, this will be reflected by normal mitochondria, because angiotensin II type 2 receptors, as I mentioned in the beginning of the presentation, this is the beneficial and a friend receptor. But angiotensin II type 1 receptor is an enemy, it's bad. Hydrogen sulfide ameliorate oxidative stress, inflammation, everything, and protect the kidney. But the problem how to offer hydrogen sulfide. The gas is toxic, but it may be used, and there are phase 1 studies, but the most important natural source for hydrogen sulfide is garlic, but we are not aware of the dose of garlic to protect the kidney. In gut microbiome, here, this is the concept. In chronic kidney disease, there is dysbiosis, and dysbiosis can lead to chronic kidney disease. So there is a link between intestine microbiome and the kidney. And if we ameliorate the dysbiosis to reduce abnormality of gut microbiome, either by diet, like encouraging fibers, because reduction of fiber lead to dysbiosis. Reducing animal and the carbohydrate, because increased animal proteins and increased carbohydrate, both of these bad styles of diets, reduce the fibers, excessive animal proteins, and increased carbohydrate, all these lead to dysbiosis, and as well as in insulin resistance and chronic kidney disease and beta cell failure. So this, both the concept of gut microbiome with the health of the kidney and diabetes as well. And this is the one of the recent articles in this issue. Modulation of the diet and gastrointestinal microbiota normalizes systemic inflammation and beta cell chemokine expression associated with the autoimmune diabetes susceptibility. This means that we still need to know a lot about microbiome, how to target them for the sake of the kidney and pancreas. Another pathway which is very important for anti-aging, autophagy. Autophagy is reduced in diabetic patients and in diabetic kidney disease, and if we encourage autophagy, this will be a beneficial effect against renal injury. So autophagy, insulin resistance reduces autophagy, obesity and dyslipidemia reduces autophagy, hypertension reduces autophagy, kidney disease reduces autophagy, diabetes and pancreatic disease reduces autophagy, with subsequent many problems leading to cytotoxic aggregates of dysfunctional organelles and pathology. This is why we are stimulated and excited by the data of autophagy. This is why we have this MD nephrology thesis of Dr. Samar Ahmed. She is an assistant lecturer of nephrology at Qanat Suez, and she is a candidate with us at Mansoura University for MD nephrology. So she created the type 1 diabetic rat model. And so we have diabetic rats. Diabetic received mTOR inhibitors, rapamycin and metformin, and rapamycin only versus other control. If you look here in a diabetic rat, this is the basement membrane after 3 weeks of creating diabetes, and after 10 weeks. After 10 weeks, there is increased thickness of the basement membrane with reduction of autophagosome that reflects autophagy. And this is the immunohistochemistry in diabetic rat. Here, the LC3 is significantly reduced in this diabetic rat model. But if the diabetic rat is treated especially by rapamycin, you can find here the increased autophagosome. All these are autophagosome that are increased, and the membrane is normal after the period of time. Look here, the expression of LC3 by immuno testing is significantly enhanced. This means, and LC3 is a reflection of autophagy. So preservation of autophagy reduces the basement membrane thickness. This means it improves and ameliorates diabetic kidney disease in an experimental fashion. So the data is still unpublished, and so this is why we are still waiting the publication of the full manuscript. Again, for chronic kidney disease progression, either diabetic or not diabetic, there are many risk factors for CKD progression. including albuminuria, hypertension, episodes of acute kidney injury, obesity, hyperlipidemia, smoking, high protein diets, metabolic acidosis, hyperphosphatemia, hyperuricemia, hyperglycemia. So this means that it's impossible to discuss all these issues in one or two presentations. So if we know these are the risk factors for development or progression of diabetic kidney disease, so the idea is to combat them in a comprehensive risk management manner. So this is a review article for this issue, comprehensive risk management of diabetic kidney disease in patients with type 2 diabetes. And within this review, you'll find paragraphs about strategy for remission and regression of diabetic kidney disease. And if we go to in details to some studies in a long time ago, you'll find these articles. If we address no factors, regression and remission is the one. But if we address one risk factor, regression and remission of microalbuminuria is increased. If we address two risk factors, the regression or remission increased. If we address three risk factors, here 5-fold increase in regression and 6-fold increase in remission. This means that if we work on all factors together, hyperglycemia, hypertension, diet, exercise, this may make a big difference in nephropathy. This is the randomized control study of 7.8-year follow-up, including 160 patients, addressing the issue of multifactorial intervention and the cardiovascular disease in patients with type 2 diabetes. Look here, nephropathy is significantly reduced by multifactorial management. The patients have persistent microalbuminuria. Again, even after 13 years, nephropathy is significantly reduced in the intensive therapy group in comparison to conventional one. Remission of diabetes in nephropathy in type 2 diabetic Asian population, here controlling here multiple factors, especially hyperglycemia and blood pressure. In this number of patients in cross-sectional study, cohort study this is a cohort study for approximately 5 years of follow-up showing beneficial effects. Again, association between remission of macroalbuminuria and the preservation of renal function. If we succeed to reduce albuminuria by multifactorial management, this will be associated with preservation of kidney function. This is a long-term observation, 21 years, Steno 2 randomized trial. Here you can look, all-cause mortality are reduced, cardiovascular mortality is reduced. Here macroalbuminuria is significantly reduced by applying intensive and multifactorial intervention with reduction of end-stage kidney disease in comparison to the other one. Intensified multifactorial intervention in type 2 diabetes with microalbuminuria lead to long-term renal benefits. This is a dogma, and this is I believe in this to address all risk factors as we can to improve healthcare system. This is very fantastic. If you look here through different time periods, you'll find superiority of intensive versus conventional. So here 69 GFR in comparison to 54. CKD stage higher than 3B. It is here 45 in conventional and 20% in intensive. Urine albumin excretion rate here 120. This is the median. Macroalbuminuria here 43% in intensive and 64 in the intensive. In the convention 64 and in intensive 43%, with subsequent improvement of the rate of impairment of the kidney and reduction of GFR is ameliorated in the intensive multifactorial management group. So multifactorial group are associated with significant preservation and less progression of diabetic kidney disease. If you look at this heat map you can find here. This is 20-year follow-up. Here, if we apply intensive management, the patient are living with no end-stage kidney disease, approximate 50% after 20 years. But here, it is 25% after 20 years to find living patient without end-stage kidney disease. And the other patients are either end-stage kidney disease or died. So the intensive multifactorial managements are associated with more beneficial effects on kidney life. This is the recent study, effect of an intensified multifactorial intervention on cardiovascular outcome and mortality in type 2 diabetes, an open-label randomized control trial. Although this study included large number of patients, but showed no strong data to recommend multifactorial treatment, but again, the nephropathy is significantly improved and significantly less in the intensive treatment group, although all the other parameters are not so strikingly significantly changed. Holistic approach is the key of success. Holistic is to treat everything. To treat diabetes, targeting cardiovascular risk factors like hypertension and dyslipidemia. If you look here, solid line means that the drug is beneficial. So statins are beneficial toward reducing cardiovascular disease. Here, S inhibitors or ARBs are solid, beneficial for cardiovascular and for diabetic kidney disease. Mineralocorticoid receptor blockers are beneficial for diabetic kidney disease and cardiovascular disease. Sodium antidiabetic drugs, sodium glucose cotransporter inhibitors are solid. This means very beneficial for cardiovascular and diabetic kidney disease. GLP-1 receptor agonist is the same. Here for the DP4 inhibitor, the evidence is inconclusive. For fibrate, the evidence is inconclusive. For diuretics, the evidence is not conclusive. So this is very nice to target hyperglycemia, diabetes, and hypertension by proper drugs for the safety of the patients. One of the most important observations that I like it, 11 million persons from 66 studies. Here, this is the metabolic syndrome and its component and the relationship with the chronic kidney disease. So the odds ratio for chronic kidney disease based on the presence of metabolic syndrome. Metabolic syndrome increases chronic kidney disease by 50%. And this is if fasting glucose is high, increase by 38%. And here, if we have one component, there is the increase. This is the percentage of increase in CKD. The more the components of metabolic syndrome we have, the higher and higher the risk of CKD. This is why we should target all the components of metabolic syndrome, not only of diabetic. And one of the important issues is to encourage the use of risk calculator of diabetes. If we wanted to prevent diabetes, we should calculate the risk, because if we calculate the risk, if we put the data, if we fill in space here on the calculator on Google, you will find these patients have 8 points. And so high risk, this patient has high risk for diabetes, and because score above 5 should be formally screened for diabetes, and we should encourage him for risk factor modifications. So this is the avenue for primary prevention of diabetic kidney disease, is to prevent diabetes. Maybe using proper diagnostic facilities like nanotechnology based point of care diagnostic device, very simple device showing a lot of data, showing the hemoglobin and other parameter in one test. This is the hemoglobin A1C, serum albumin. So you can know all these data just putting the strip here, and this will help a lot in the treatment of the patients. We hope that during the evolution, we should have the personalized medicine. We can characterize the patient for the best treatment, not only because of albuminuria or high creatinine. These are the clinical parameters that we have, but according to the advanced molecular. If we know this and it become feasible and available in the future, we may select treatment for each patient, so this patient have his unique treatment and this patient has another treatment modality. We need a lot of research, so this is why I'm happy that there are conferences speaking about clinical trials in diabetes. So we need trials in diabetes. We need basic research, and we need to know, we need training and education, and always I am believing in, if I am living because I am learning. This is why we are very careful about the ESRD Virtual Academy, and we have now this figure of lectures and videos on this academy. To end, we should know our patients, we should have research, and we should continue learning, because William Osler stated that he who studies medicine without books, without education, without training, sails an uncharted sea. So he is in a sea and he doesn't know where he is. But he who studies medicine without patients, this is why we should sit together with the patients in a holistic approach, and both in the patient in shared decision, and both in the patient on our focus. By this way, learning and taking experience with the patients, this will make a big difference. So he who studies medicine without books sails an uncharted sea, but he who studies medicine without patients doesn't go to sea at all. Thank you for attention, and I'll be happy if you have any question to send to my email.